Hello, everyone, and welcome to today's webinar, Setting a New Standard in Advanced Wound Care with the Flex 360 Revolution, a clinical case series. Before we get started, I'd like to go over a few items so you know how to participate in this event. We've taken a screenshot of an example of the attendee interface, so it should look something similar to this on your computer desktop, and you've joined audio listening through your computer speaker system by default. But if for any reason you'd like to change how you join audio and do it through the phone, you simply select phone call in the audio section of your control panel and the dial-in information will be displayed. You can submit questions to our presenter by typing them into the questions box of your control panel, and you can submit those questions at any time. We'll collect them and address them during the Q&A portion at the end. There is a product sheet available for download in the handout section. So just look for that section in your control panel. To save it, you'll click on the title. It'll open in a separate window, and then from there you can download or print it. I would now like to introduce our speaker, Dr. Kevin Wu. Dr. Kevin Wu is an associate professor at Queen's University School of Nursing, School of Rehabilitation Therapy in Kingston, Ontario. He is the regional director, North American, of the International Skin Tear Advisory Panel and the web editor for the Advances in Skin and Wound Care website, plus an advanced wound consultant. Welcome, Dr. Wu.
Well, thank you so much. Lovely to be able to join you this evening for this presentation. So first of all, just my disclosure in terms of different companies and organizations that I work with and present on their behalf. And thank you for Monica for sponsoring this event. Well, first of all, I hope everyone is enjoying a little bit of heat. It's like 34 degrees in Toronto today, hot and humid, so we're enjoying a sweltering summer so far. So what I want to do this evening is to go through a few things about pressure injury with you as you aware the latest update from the National Pressure Injury Advisory Panel. They published the newest guideline in 2019. So I wanted to highlight some of the key elements in the newest version of their best practice recommendation. And out of that, I want to look at the benefit of using a flex foam dressing and highlighting the conformability, absorbency, and the ease of use through a number of case studies. And of course, we love to see pictures and cases. And so I'll discuss some of the results from my case studies. And at the end of the presentation, I want to highlight another study that we have just completed using the silicone dressing for the treatment of skin tears. And I think with some exciting news to share with you today. So first of all, I think pressure injury continues to be a very, very common problem across different sectors. We did look at some of the literature. This is a study by a group of Australians. They look at 38 different studies around the prevalence and incidence of pressure injuries in 11 countries. And lo and behold, of all the different types of wounds, they looked at venous leg ulcers, diabetic foot ulcers, pressure injuries, and pressure injuries continue to the most common chronic wound type reported in the literature. The prevalence is estimated to be as high as 26% in acute care, about 29% in community care, and in long-term care is as high as 50%. As you can imagine, during the whole pandemic situation that we are encountering right now, the prevalence of those pressure injuries is even much higher compared to the normal state. And as you can see, the incidence is really a good indicator for the quality of care that we provide for our patients. 29% over a 6-week period in acute care, people develop some type of pressure injuries. And in other words, it doesn't really take long for people to develop problem, and a high percentage of people develop issue. We did a small study in Ontario looking at about 200,000 individuals within a 3-year time frame. We looked at data from acute care, home care, long-term care, and complex continuing care in Ontario. The overall pressure injury rate was about 13%. Much higher in the complex continuing care. I know not all the provinces have complex continuing care. So that's the population that have a lot of complexity of healthcare needs, including feeding tubes. They may have existing pressure injury or other skin lesions already. They're usually immobile. They may be on ventilators. So a very, very complex population, as you can imagine. And what we have identified and discovered in this study is the fact that about 70% of individuals in long-term care environment, they have more than one lesion, not just one, but multiple ones. And also 28% of pressure injuries on long-term care, those individuals develop problem within a week when they return back from acute care. So I think the message is a lot of those individuals are very vulnerable to developing pressure injuries. And also I think within the transition period, we need to pay more attention in terms of identifying the risk factors, and so we can prevent the pressure injury problem. Okay, as people know me, I like to ask questions from time to time just to make sure that we're all awake, especially during the time in the evening after a big meal, right? So from your perspective, what are the primary causes for pressure injuries? And you can click as many choices as you like. There are 5 choices here: pressure, shear, friction, microclimate dysregulation, and tissue deformation. Let me see your votes. And too bad I cannot really play music for you. I don't think you want me to sing. All right, very good, interesting result. So 100% of people say this is related to pressure. A lot of people say shear, and friction, interesting enough, about 84%. And then we have microclimate and tissue deformation to follow those choices. Very interesting finding here. Now, I think there's very little doubt that pressure injury is really the primary etiology is in relation to pressure problem. As you can see in this diagram, with increase in pressure, and the magic number is the 30-something mmHg pressure that can occlude the circulation, compromising the blood flow. So the result is tissue necrosis or the toxic material buildup that can cause direct cell death. So, and you can see the pressure can cut off the circulation and leading to a whole cascade of physiological event. And we know that pressure and shear really are the primary reason for people to present with pressure injury. And just a reminder, pressure is the perpendicular force that directly works against the tissue over, especially the bony prominences. And then the shear is the oblique force that have a tendency to separate the superficial layer of the skin or the tissue from the deep compartment. So the end result with significant amount of shear, it can actually stretch the blood vessels. Eventually, it can break down the blood supply, and that's why people develop pressure injury. And often, when I teach people about how to recognize the shear damage in pressure injury, look for those underminings. If you have a lot of undermining, and that's really indicating the direction where the tissue is moved against, and separating out the superficial layer from the deep layer, and that's why there's a big gap between tissue layers. And the other key concept, and especially what they've highlighted in the newest version of the NP-IAP guideline, is the importance of soft tissue deformation. And I'll come back to talk more about tissue deformation. But the interesting part from all the physiological and experimental data in animals and humans is that we know people can develop pressure and shear injury within hours. So think of your patients in the emergency department on a stretcher not being mobilized. Think of your patients in the operating room not being mobilized for prolonged duration of time. And we all recognize that people can develop those type of pressure injuries within hours, not days. And the more alarming thing is the fact that people can develop pressure injury due to tissue deformation within minutes. So I think no longer do we say that, well, people don't develop problems within minutes. now we recognize that tissue deformation could be very significant. So what is tissue deformation? First of all, you need to recognize there's something called cytoskeleton, and this is a nice diagram to depict the skeletal or the infrastructure of a cell. So all these little intricate laces representing the cytoskeleton. So when there's pressure, when the cell gets stretched, it will stimulate those microfibers, the cytoskeleton. And as such, it can stimulate or generate a number of cell signals, eventually leading up to cell death. So whether you stretch from shear or compress from pressure, changing the cytoskeleton, causing tissue cell deformation, and depends on the load, and extreme or intermediate load can eventually leading up to cell death. And in the new guideline, they actually have this diagram really illustrating the effect of tissue deformation in comparison to what we have known about inflammatory damage and ischemic damage that causing pressure injuries. As you can see in the blue line, with the combination of tissue deformation, inflammation, ischemia, you got this cumulative damage, a very steep slope within a short duration of time. With even low pressure and low shear, it can cause significant amount of damage. You can see that deformation, the curve is above inflammatory, above ischemic type damages. The other key concept, and it's not in the multiple choice questions earlier, is about tissue tolerance. And it ties in nicely with the concept of tissue deformation. What you can see here are two individuals, one with obesity and one with normal weight. But it doesn't matter. What we're really interested in this picture is looking at the muscle layer. A person with normal muscle versus a person with muscle atrophy. Whether the person have spinal cord injury problem, they're not using the muscle, it undergoes atrophy, or individual who are not walking, who are not mobilizing, of course, when you don't use the muscle, it will undergo atrophy as well. So what you can see here in the red color, the patient A with muscle atrophy, the tissue damage occurred much earlier with a lot of muscle load. When there's equal amount of pressure, there's a lot of tissue damage, and representing the tissue is not able to tolerate a high level of pressure and shear, compared to patient B with normal tissue layer, and they're able to tolerate the pressure for a longer duration of time. And it's interesting that a lot of you highlight friction as a primary cause for pressure injury. But in the newest guideline, they actually downplay the importance of friction. When you think about stage 3 and stage 4, the deep pressure injuries, the primary causes are from pressure, shear, and now we recognize the potential damaging effect from the tissue deformation. Friction may play a very minor role in stage 3 and 4 pressure injuries, and their contribution is primarily towards the stage 2, the superficial type pressure injuries from the rubbing, causing the erosion of the epidermis. The other factor is in relation to the microclimate. For people not familiar with this term, microclimate is a concept that has two major factors. One is humidity, the moisture on the skin. The other factor is temperature. We know that when there's elevation in temperature, there's an increase in metabolic demand. So people with pyrexia, with fever, with increased temperature, and also people with increased heat locally because they have all the sheets wrapping around them, all this unbreathable material wrapped around them. Of course, the skin would not be able to, the temperature would not be able to dissipate into the surrounding environment, resulting in elevation of temperature. At the same time, locally, the skin will respond to increased temperature by causing a sweating response to dissipate, to remove the heat. So the combination of heat and moisture can change the coefficient of friction and shear. It can weaken the skin. Imagine the skin cells are joined together. When there is moisture, the skin cell, the junction, the connection can be weakened, so that will allow the skin to break down more easily. So think about incontinence. Think about people sweat who are very diaphoretic. Think about wound exudate that can leak into the surrounding skin. Whatever source of the moisture is, with increased humidity, the skin integrity is weakened and can cause skin breakdown. And the end result with the change in microclimate, it increases the risk for pressure damage and pressure injury problem significantly. And that's why in the newest guideline, there's a talk about the importance of regulating the temperature. Just a reminder not to put too many layers of material. The more layers you have, the more likely you're going to facilitate the accumulation of heat. And there's a lot of new literature using different types of textiles to dissipate, to allow the heat to be removed more easily. We actually recently been doing some evaluation using a real-time skin data platform. Is a sensor we place underneath the patient to collect data on the microclimate, the temperature, moisture, and pressure at the same time. And the purpose is to identify which factor and how the combination of those different factors at different time, because we continuously collect the data from minute to minute over 24 hours. Perhaps we can identify patients at risk for developing pressure injury at an earlier time. So hopefully I will come back to tell you more about the study results once we have completed this. So the other recommendation out of the NPI-AAP recommendation, in order to address the pressure and shear problem, and potentially with the microclimate, and to reduce the damaging effect of pressure and shear on the tissue deformation, perhaps we should be able to use a foam dressing prophylactically to reduce the pressure and shear problem. And I'm sure everyone has experiences of using a foam dressing. It's a very distinct category of dressing material. It comes with, there are many different companies. There's at least about 100 of different types of foam material out there. They're different in terms of composition, thickness, absorbency capacity, different shape, and different location for different locations. The different adhesive properties, and because of the different adhesive they use or the location, it has different peel forces and potential for injury to the skin. And most of the foam material are comprised of two major ingredients. Either is the polyvinyl alcohol or polyurethane material. They can be woven or not woven, and the structure could be quite different. I think most of the modern foam dressing are much better compared to the first generation foam dressing that we saw before, like 10 years ago. I still remember some of the foam dressing, when you squeeze the fluid, once they absorb the liquid, you squeeze foam dressing, you can actually see drops of fluid coming back out from the foam dressing. But with the more advanced technology, with the cell sizes and the cell structure being quite different inside foam dressing, now most material can actually lock the fluid inside the dressing material. And the most important part about the application of foam dressing to address pressure injury in the NPI-AAP guideline is very clear. It's not about every different types of foam dressing. It's about the multi-layer foam dressing that has the best evidence to support its use in clinical practice. So most of the foam dressings, multi-layer foam dressings, are very similar. They have multiple layers. They have the outer, the backing, whether it is permeable or semi-permeable. And then you have the drainage retention layer to absorb the liquid, and also a dispersion layer to allow the fluid to spread into the dressing material, and also a contact layer. And depends on the different technology and different industries, they will have their own patent interface in order to enhance the absorption and also to allow the interface to adhere to the wound surface without traumatizing the wound. As you can see, a lot of foam material and the multi-layer foam dressing is able to absorb the liquid into the foam dressing. So how does multi-layer foam dressing work? And I can think of a few mechanisms, and this is based on a paper written by Evan Carr and his colleagues, enhancing pressure ulcer prevention using foam dressings. What are the modes of action? So I add a few or vignettes also to just highlight how foam dressing can work. So first of all, with a multi-layer foam dressing, it depends on the size of the material. It can displace the shear outside of the dressing area. So in other words, when you're thinking about using foam dressing prophylactically, think of a larger size of foam dressing. I know as clinicians within the healthcare system, we're very cost conscious, we're trying to be very frugal. We want to use the smallest dressing as possible. Sometimes we might want to even cut the foam dressing. But this is not really the time to be cost saving here, because if you use a small dressing, the displacement of pressure and shear is only very minimal versus a larger size of dressing that you can optimally displace the pressure and shear problem. The other important part is, especially dressings with a foam adhesive or with the silicone adhesive or the silicone interface, the elasticity of the silicone, because of the bounciness, the elasticity is able to absorb some of the pressure and shear. And the other concept is what we call the bulk modulus, and also the cross-sectional distortion. As you can see in the diagram, as the foam material, as any type of material change shape, it can absorb the mechanical forces. So the bulk modulus is reducing the bulk size of the material. The foam material, once it's under pressure, it will become thinner. The fact that it can become thinner, become more compressed, through the process changing in shape, it absorbs a lot of the pressure and shear. The same as cross-sectional distortion, the ability for the material, for the dressing to bend, to conform to the contour of the body part. The ability to bend, changing shape again, absorbing the mechanical forces. So, and then you have the multi-layer, and that's the whole catch about why multi-layer system or multi-layer dressing is better than a solid single layer. Because so far we don't really have any good evidence that a solid single layer foam dressing is equivalent to the performance of a multi-layer foam dressing. Not yet anyway. So the theory is with multi-layer foam dressing, it can slide against each other to provide that shear reduction mechanism. And also depends on the backing of the dressing material. It usually is a semi-permeable membrane, allowing the vaporization, allow the moisture to be lost into the environment. In that way, you can regulate the microclimate, regulate the moisture level in between the dressing interface and also the skin. So, and I think you can see the different mechanism involved. And when there's another study done by the same group of people, by Evan Carr and his group, looking at this sort of simulation program. What they did was evaluating different types of foam material and setting up a platform with a sensor, a pressure sensor, and place a foam dressing over it in one group, and the other group has no dressing. And then to slide something over the sensor to see if the foam dressing actually reduced the amount of force against the sensor. And what they found, and in comparison between the Macroscopic group and the control group in blue color, you can see a significant reduction in the shear forces detected by the sensor. So again, in the experimental study in a lab, they're able to demonstrate how effective it is by using a dressing prophylactically to reduce shear. So, okay, let's see if you're still awake. What factors can help you decide on dressing selection? And we have a few choices here. You can select more than one. Exudate, location of the wound, pain, peri-wound skin condition, or types of wound. There's some answers are better than the other. I'm curious about your choices now. All right, we have a couple seconds for you to respond, and here we go. Exudate, I agree. Location of the wound, interesting. Pain, only 75%, eh? Well, hopefully I'll convince you at some point during this presentation that patient suffering is an important indicator or a component that we need to consider when you're choosing a dressing. And definitely peri-wound skin condition. Types of wound, interesting enough, we have 94% of people respond that this is a key indicator when you're doing a dressing selection. And that is the one choice that I thought it would not be the best answer, because if you think about the different types of wounds, and when I do presentation like this, one of the questions often raised from the audience is, I got this pressure injury, what kind of dressing should I use? I got a foot ulcer, what kind of dressing should I use? Well, the answer is it all depends, famous answer, right? Because it depends not just on the wound types. The wound type doesn't really matter. What really important is how much drainage is coming out from the wound. You want to address the wound exudate level. You want to make sure that you address the ability for the dressing to stay on the skin. Whether it's a pressure injury or venous leg ulcer or diabetic foot ulcer, it doesn't matter because they can all produce high volume of fluid. So I'm hoping that again, to convince you that when you're selecting a dressing, think about 1 to 4. Number 5 is not the most important indicator. And in order to help people to remember some other key parameters when you're in the process of selecting the appropriate dressing for your patient, think dressings, question mark. Actually, Michelle from BC and I, from Alberta, and I had come up with this acronym to summarize some of the key elements we think as clinicians are important. So D for dimensions, obviously, if you're selecting a dressing, you want to make sure it's the right size of material. And the rule of thumb is if you're selecting a foam dressing and you have a wound, you need to have at least about 2 centimeter margin in order to enhance the adhesion to the skin. And R for resources and costs. A lot of times depends on your practice location and depends on whether you're in the rural or urban area and the type of hospitals or settings you're in. You may not have the material, the type of dressings that you have. You have to think about costs. Exudate, I think this is one of the major factors in terms of the amount and viscosity, the type of fluid coming out from the wound. Site, yes, I think especially with pressure injury, you do need to think about, consider the contour of the location. With most of the pressure injuries being in the coccyx and sacral area, it's a big challenge for us to come up with the correct and appropriate dressing to cover the location. And one of my pet peeve and one of the most commonly raised complaint about the use of any type of dressing for coccyx injury is that those dressings have a tendency to roll up, they tend to detach itself, they tend to get contaminated by stool, urine, and other material. So as a result, they come off very easily. So I think we just need to think about other type of dressings that has a better ability to conform to contour and stay on the skin. So that's a big factor. Another S for surrounding skin, looking at the peri-wound skin. I for infection and biofilm. Obviously, when you're concerned about local infection and biofilm problem, then you might have to add antimicrobial ingredient into the dressing material to help reduce the bioburden in the wound. And for necrotic tissue, and some of the material are better for promoting autolytic debridement than others. G for gauze. And depends on whether the wound you consider to be healable versus non-healable. Your entire approach, your plan of care will be very, very different. And as for suffering, and that will include pain, and hopefully that you reconsider your choices earlier, that pain is an important indicator. When we're doing a lot of the research in dressings, often we consider wound healing as a very important outcome. But I think about what the patients will wear and patient adherence to treatment. It all depends on what's comfortable to them. So pain is a very important indicator as well. And then the question mark is is we want to remind people the importance of asking questions to your caregivers, to your patients. What are the concerns? Can we address the concerns? Even though we thought that there's some parameters we should be considering when we select dressing, perhaps patients know better. All right, what are the key problems associated with wound dressings? I kind of mentioned a few of my concerns. Let's see if you have any, well, let's see your responses based on the few choices available to you here. The dressing won't fit. It can't contain wound fluid. It can control or protect wound from fecal contamination, or it won't stay on the skin, period. This could be interesting. Couple seconds. And here we are. Okay. Lots of people mention the foam dressing. They don't stay on the skin very well, and definitely there's some problem with protecting the wound from fecal contamination. Of course, depends on the type of population that you see and the type of stool contamination as well. So interesting. And I think that's why we need some better technology. I'm sure that you have seen pictures like this, or some recent experiences of dressings that doesn't really quite conform to the contour of the body. And in this case, what you can see here is a foam dressing that doesn't really quite conform the contour, and resulting in a big gap. And now the stool and urine can actually get in. Right now you can see the picture better. So you can see there's a lot of times that the dressing may not fit with the contour of the body, and that's why it won't stay on the skin. So again, some of the biggest challenge of wound management, and very, very similar from what you have verbalized and voted earlier, is early dressing detachment, lack of conformability and comfort, the ability to manage or handle wound exudate is poor, and also the whole patient complexity is part of the holistic care of a patient care. And that's why I want to introduce to you another member of the Macroscopic family. This is the Macroscopic sported flax, and I'll explain to you about the flax capacity a little bit. So basically, the dressing material is quite different compared to the regular Macroscopic material. It does have multiple layers, and as I mentioned earlier, the different layer components that you can see with the absorbent core, and then you have the contact layer against the wound surface and the peri-wound skin. The also interesting thing is you notice there's some wide cut on the dressing surface. They allow the dressing to be more stretchable, and the stretchability has a lot to do with how the dressing can conform to the contour of the body. And also the interface of the dressing itself, it is atraumatic. It doesn't cause any skin stripping problem. So, and of course, one of the major factor is the dressing is able to absorb a lot of the wound fluid. And this is a histogram comparing Macroscopic sported flax with a number of leading foam dressing in the market. And in the lighter color indicating the amount, the volume of exudate absorbed in the foam dressing, and the darker color indicating the moisture vapor loss through the backing of the dressing. And consistently, the Macroscopic sported flax is able to outperform other leading foam dressings out there in the market. And also, one of the major concerns is the viscosity of the wound fluid. When the wound fluid is so thick, is able to get through the interface and get to the core and locked inside the foam dressing. A lot of the material foam dressing in the past is not able to handle the thick viscous exudate. You end up with all those murky, thick layer of tenacious material sitting on the wound and causing more maceration in the peri-wound skin. So again, this is another table looking at the lab testing, comparing the Maplex border flax with other dressings, and you can see that it's able to handle high volume of exudate, whether it's normal or viscous. So I think that's why we keep coming back to the key concept that we found the dressing is better performed than a lot of the material that we see. And as a result of the Y cut, and this is a closer picture that you can see with all the cut on the dressing material, allowing the material to flex, to bend, to change shape more easily. And that result in longer wear time. It's more comfortable to wear. And the SafeTech technology is similar to a lot of the material that we have seen on Maplex. And because of the silicone material is atraumatic, it's not likely to cause injury upon removal. And the pure force required to remove the dressing is less than a lot of the adhesive that we see. So I want to share with you a few cases here. This is first patient. And she actually from the complex continuum care setting, she has problem with mobility, and she, like a lot of patients in the complex continuum care and long-term care facilities, they like to be very sociable. They like to be sitting up in a chair for most of the time. And in this case, and that's what she's been doing, and result in a pressure injury on the ischial porosity. And the problem is she likes to be sitting in a chair and refused to be changed until she went back to bed. So on the usual day, she'll be sitting in a chair, in a wheelchair, for prolonged duration of time, from 8 hours to easily to 12 hours from time to time. So, and of course, we had to change the pattern, and and we did convince her to cut down the hours sitting on a chair. And also, we've been sort of testing and trialing different types of dressing material. And we've been very frustrated with the different material in terms of the dressing ability to handle the fluid. There's always leakage. And also, because she was incontinent, the urine is always sipping and leaking and into the dressing. And at the end of the day, the dressing is basically drenched, soaked with urine. And you can imagine the skin exposed to the urine for prolonged duration of time, the potential damage it can cause, right? So, and that's why we thought that, well, let's try the flax dressing. And we're quite interested, it's quite interesting to see the outcome in this picture here. So first of all, the fluid, as you see, this localized, locked inside the dressing itself. And you can see the stain on the dressing here. It doesn't really quite spread to other places and just basically lock right in the dressing itself. So, and we continue to allow the dressing to stay on the skin because probably that's not quite a good indication to change that yet. So when we, just before we change the dressing on your right-hand side, this picture here, so you can see now the stain is growing bigger, there's more fluid, and still the fluid is not leaking out from the dressing itself. And there's no evidence that the dressing is drenched and soaked with urine or contaminated with fecal material. So I think this is a good picture or case to show you that the dressing itself, because of the flexibility, the conformability, is able to create a very localized sealed environment to lock the exudate up in the wound, in the dressing itself, and prevent external contamination like urine and stool from getting into the wound. And we also know that the foam dressing, they're quite different in terms of the different material they use. And one way to evaluate the dressing performance is not just about how well it can stay on the skin. That's clearly is a good, very important indicator. But the other thing is the wear time. Does it change shape? Does it change tensile strength over time? So the wear time, the longer the dressing has been used, the more likely the dressing is going to separate, disintegrate from each other. And this is a study that they had done by Burton and his group, looking at in an experimental design study in a lab, how different dressings can perform over time. And basically, those dressings subject to different stretching forces to see if they can maintain the shape. And in this slide, you can see here in the orange color is the Macroscopic border compared to other types of foam dressing material in the market right now. And the load, the amount of stretch that is required for dressing to yield, to change shape, is much higher compared to other dressings. And even despite the passage of time, the Macroscopic dressing continued to be superior compared to other types of dressing. So this is a study published in Advances in Skin and Wound Care based on their the evaluation. And another evaluation they did in the same publication is asking clinicians now applying from the bench to the bedside to evaluate a number of indicators how the dressing perform in real life in a sort of pragmatic study. They look at a few aging effect indicator for the dressing that is disintegrating and how the dressing age. In terms of are they losing the marking on the dressing? Is there any wrinkling, bunching on the surface? Is there any evidence of fluid leakage? And the layers separating out from each other, the rolling problem, and does the dressing continue to have the ability to conform to the contour of the body, right? And what you see here, again, comparison of all the different dressings out there, and you can see Macroscopic border it seems to be at a pretty high performance level, able to perform quite well. So the other important component that because of the ability for the foam dressing material, the ability for it to lock the fluid in the dressing itself, there's a thinking that once you lock the fluid, you also sequester a lot of the bacteria along with the wound fluid inside the dressing as well. And this is what we call the bacteria trapping action. And you can see that the comparison of Macroscopic border flax compared to another foam dressing. And after an hour of contact using the Macroscopic flax, the fluid got wicked away from the petri dish along with the bacteria. And after an hour of incubation, you don't see any colonies. There's no indication of bacterial growth. As opposed to another type of dressing, the material, the fluid, yes, it may be able to wick away a little bit into the foam dressing, but the bacteria continue to be staying on the petri dish. And after an hour incubation, you can see a number of colonies growing on the petri dish. So I think we probably need some more rigorous design study to evaluate this bacterial trapping property to see how it can reduce the bacterial burden and potentially even address the biofilm problem. As you're aware, biofilm is the ubiquitous existence in chronic wound due to bacterial growth. So if we can control the bacteria, the number of bacteria in wound, perhaps we can reduce the number of biofilm problems. That seems to be the primary reason why chronic wounds become chronic. So again, this is another lab study indicating in the lab the ability for the Macroscopic foam dressing, the Macroscopic border flax to the ability for us to retain the bacteria even with compression 8 times higher than some of the other dressing that you can see on the slide. The other interesting thing that we have discovered from using this particular flax dressing, because of the ability to seal, create a sort of sealed environment to protect the wound, we use fluorescence light from time to time imaging technique to evaluate bacterial growth. And in this case, we look at the wound, this pressure injury problem, and we put a Macroscopic border flax to cover the dressing. And when we change the dressing and we evaluate the presence of bacteria, what we surprised to see is we didn't see a lot of bacteria inside the wound, and not in the area immediately outside the wound where it's covered by the Macroscopic flax. What's surprising is there's more bacterial growth indicating in the bright color um, in the periphery, in the area where it is not covered by the foam dressing. So indicating that if we're not creating the seal, the bacteria, either from urine or from the fecal material, they continue to colonize on the skin. And it's great that we're able to protect the wound from this contamination. Otherwise, I mean, there would be increased risk for local infection problem. And this is a case, again, from the hospital. What you're looking at is right around the front of the ankle area. This is a pressure injury, believe it or not, induced by compression bandages. When the compression is cutting too tight, especially when the person, the location and how it's being positioned, the ankle area, it can create a crease area where there's a lot of pressure against the skin. So we actually use the Macroscopic flax dressing to see if we can reduce the pressure, reduce the injury, and promote better healing. And I'm showing this picture because despite the use of compression, the dressing is able to perform quite well. It stays in place, it's able to absorb a lot of wound fluid. And you can see that the wound fluid is locked inside the dressing. And compared to the first picture, now you can see the wound is cleaner and there's a little granulation tissue surfacing into the wound bed. And in 2 weeks' time, it has reduced by about 30% in size. And you can see the injury is no longer as obvious. I think in the earlier picture, you can almost see the purple color in the per-wound skin. So it does suggest to us that flax dressing has the ability to reduce the pressure problem. And then in another 2 more weeks, by week 4, this wound has improved so much and is almost healed. And the other sort of a newer thought that I have around the management of pressure injury is to reduce the amount of fillers and packing material into wounds. This is a series of cases that I published with another clinician in the International Surgical Technology, really highlighting that for a number of pressure injuries that we cared for, since we have removed the packing material and replaced the dressing with primarily just a good superior absorbent foam dressing, we're able to see better outcomes. Because especially for pressure injury in coccyx area, for individuals who are bedbound and not able to mobilize very well, if you have a bulky, lumpy dressing material, it can cause a lot of pressure damage to the wound bed. So by removing all those packing material or minimizing the packing material and using a better foam dressing, we're able to promote better healing. As you can see in this case, in 2 weeks, you can see a significant improvement in size and the amount of granulation tissue there. And if you're not convinced about the importance of conformability, I want to show you this is a study done by the lab, and also Dr. Emma Gavin has done a number of evaluation in his lab. He's a very good scientist, bioengineer, has been involved in the pressure injury research for a long time. He's part of the board from the NPIAP as well. So what they're able to demonstrate here is that compared to other dressings, the Macroscopic flax dressing is able to reduce the pressure on the contact level, on the contact interface. As you can see, the red color indicating high pressure versus blue color is a very low pressure gradient. So with the Macroscopic flax dressing, because of the conformability, allow the material to bend and compress more easily. Now you can see that there's a reduction in shear and pressure. What about the surrounding around the border? Yep, you can see there's a lot of red color on this dressing, this competitor, versus for the Maplex border, you don't really see a lot of the red discoloration, validating that there is a reduction in the stress on the peri-wound skin. If you're not convinced, think of this case. I was using a foam dressing under compression, and you can see the indentation that particular foam dressing has created on this leg. The amount of the material, especially around the wound edges, around the foam edges, it cut right into the skin, causing more damage. And so immediately I thought, well, there's a need to really address this issue. You can see the significant amount of problem that the indentation left behind. So we changed it to the Maplex border flex, and because of the flexibility, the conformability of the dressing, and you can see in this picture, you don't really see the indentation, the significant indented skin anymore. And the marking is gone, and the wound is progressing to healing, is improving. And by week 4, we can see the wound is literally closed, and now we can remove the dressing and continue with the compression therapy for treatment. Another patient with a lot of moisture issue, as you can see, we actually use a cyanoacrylate, a type of barrier to paint over the lesion because it was constantly irritated by urine. And similar to the first case I presented to you, that when the person is incontinent, the urine has a risk to get into the dressing, causing more maceration problem. So we again use the Maplex flex material, and the idea is to create a sealed environment, prevent moisture problem, and understanding that microclimate dysregulation is the primary reason for pressure injury to occur. So you can see how well the dressing is able to conform and fit to the fold of the skin without any serious bunching detachment problem. And it's really like fitting the area like a glove, conform to the very sort of undulated contour here. And again, in about 2 to 3 weeks, you can see the ulcer is practically closed, and now we can resume the usual care. At the same time, I actually told the nurses not to use a brief, because I think part of the problem is also from the brief cutting into the gluteal fold, causing those type of pressure injury problem. And I think this is the last few slides I just want to share with you our interesting study looking at skin tear and skin tear management. As you can see, there are many different types of skin tears. And in this randomized control trial that Dr. Kim LeBlanc and myself had just completed, we compare Maplex flex to a control group using non-adherent dressing material without the silicone. So with silicone material, you can see all the wounds progress to healing. And so we set out to ask a few questions in this study, looking at the proportion of skin tears that can heal, comparing soft silicone versus non-soft silicone dressing, and looking at healing rate differences over time, and also looking at the wound size. So it's a prospective pragmatic randomized controlled trial. We follow all those patients for about 3 weeks because we believe that most skin tears should be able to achieve closure by 3 weeks. And those are the inclusion, exclusion criteria to make sure that we select the right individuals to enter into the study. They don't really, all the wounds we have selected were deemed to be healable. There's no other comorbid factors that can influence healing in a significant way. So we measure the wound sizes, took photographs, and also attempt to evaluate the pain level as well. So these are the demographics. We have 126 individuals in this randomized control trial. I think this is a pretty good number to give you a convincing number of data that this is to give you the confidence that the results are pretty credible. Very typical to a long-term care setting. Most participants were female and age. We got different types of skin tears, and based on the different skin tear types, we use different types of dressings. With type 1, we primarily use either Mepotel 1 in the treatment group or the Ordress in the control group, which has no silicone interface. And these are the locations, mostly in arms and legs, and different etiologies why people develop skin tears. Most of the time, we don't really know why, but they just happen to be there. And as you can see, this is one case number one, a type 1 skin tear. We actually end up using the Macroscopic flex in this case. And by a week time, in 7 days, this lesion actually is healed. So what we're able to see is, in a summary, there's a significant change in the wound sizes in both groups, more so in the silicone interface group. In fact, all the skin tears were bigger in size compared to control group. On average, the mean surface area was 3.4. By the end of the trial, so by reaching the end point, meaning the skin tears were healed, or by week 2, the outer area, the skin tear area, was only 0.64. So there's a 2.9%, 2.9 centimeters square of reduction compared to only 0.6 centimeters square reduction in the control group, and the differences were significant. So I'm just looking at the time. I just want to make sure that I finish on time, because I know you all have a very busy day. I don't want to sort of delay you any further. And I really want to maybe have some time to answer some of your questions around the dressing, or if you have any comments, please feel free to let me know as well. So I think this is a good time I think we have some time for questions, Karina?
Yes. So thank you, Dr. Wu, for that presentation. And so we do have time for a couple of questions. And let's see. I'm just going to try and read through these. Does the flex stretchability bounce back, as in dynamic stress? And it looks like the suggestion is maybe like a walking patient.
Like a walking patient. Yes, I think the ability for the dressing to conform, and of course, because of the stretchability, so it actually moves with the patient, and moves with the muscle and the tissue where you place the dressing. And that's a nice thing about those wide cuts on the dressing material itself. So as you can imagine, some of the stiff dressing, and they don't conform to the contour of the body, and especially around the knee, the elbow, or area that we have a lot of high traffic, high movement. When you apply the dressing in one direction, and now you're stretching and changing the shape of the contour, the dressing can come off and fall very easily. But we don't really see that the significant problem associated with the Macroscopic flex.
Okay, great, thank you. So a couple of other questions is Macroscopic border flex covered by RAMQ or RAMQ, and what are the different sizes of the Macroscopic border flex? So those are the first two, and then there's one more attached to that.
Sure. So someone from Quebec is asking me that question. I would defer the question to the sales rep and to the RAMQ. Probably Chantel could be able to tell you better, because I'm not involved in terms of the marketing and sales. I'm just invited to speak about my clinic experiences of using the dressing from a scientific standpoint. So I have no involvement with the marketing piece.
Perfect. I think there's one attached to that, though, that will make sense for you, which is, what is the length of time the dressing should be left on for before a dressing change?
Right. On average, it's about 7 days, like most of the dressings, and of course, this is the typical answer, but the best answer that I like to give you is it depends. Depends on the volume of wound fluid coming out from the wound. And we sometimes use foam dressing because of the property for the dressing to stay on the skin and able to lock the fluid in. So we select a dressing, but we might have to change it every other day or every 2 or 3 days because of the high volume of exudate. So I think the answer is depends on the amount of wound fluid and depends on your concern about infection problem. So in some cases, you might want to monitor the wound more closely, and then you might want to change the dressing more frequently. But on average, you can have the dressing, leave the dressing on for up to 5 to 7 days.
Perfect. Thank you so much. And I think that's all we have time for. So we're going to go ahead and wrap this up. So if you have any other questions or you didn't get your question answered, please contact Wounds Canada at info@woundscanada.ca. That's info@woundscanada.ca. So we'd like to thank everyone for taking the time to attend this webinar, Setting a New Standard in Advanced Wound Care with the Flex 360 Revolution, a clinical case series. And of course, thank you, Dr. Wu, for your engaging talk and for answering some of those questions. So once you leave today's webinar, you will immediately receive a survey on the presentation, and we'd really appreciate if you would take the time to provide your feedback. You'll also have the opportunity to sign up for future updates for Mölnlycke, and you will also receive a follow-up email within 48 hours with a link to view the recording of this webinar. So on behalf of Dr. Kevin Wu, Mölnlycke, and Wounds Canada, thank you for joining us today and have a great rest of your day or evening.
Thank you. Bye-bye.